appear there, so you could tick that box and so have a higher weighted evidence for diabetes causing fracture risk, or reduce the femoral neck T-score by 0.5, or use trabecular bone score adjustment to FRAX. For this, there is a higher version of FRAX Plus. However, this is a paid app as of now. FRAX is not a paid app, and here you can put in inputs of diabetes or trabecular bone score and so on and so forth. However, for most part, we have to be satisfied only with bone density and make our own adjustments to this bone density measurement. Now, what about the effect of anti-diabetic drugs on bone health? If we could sort of look at the fracture risk, this is the last column. What we see is thiazolidinediones stand out as being associated with increased fracture risk. Sulfonylureas are sort of plus or minus. Insulin, surprisingly, has been associated with higher fracture risk in type 2 diabetes. I feel this is not a direct effect of insulin, but reflects that insulin-treated individuals are the ones who are longer-standing diabetes, poorer controlled diabetes, diabetes associated with various organ dysfunction. So this probably reflects those other conditions rather than just the fact that they were treated with insulin. So, but thiazolidinedione clearly has been shown, and for us it's pioglitazone only, which has been shown to be associated with lower bone density measurements and higher fracture risk in women in particular, not quite in men very strongly, though there is evidence that even in men the BMD tends to be lower, and there is some suggestion that in men above 50 also the fracture risk is higher with thiazolidinediones. So in terms of bone health, I think despite all the good things that we know of pioglitazone, possibly we need to be cautious about its use, especially in post-menopausal women with type 2 diabetes. And then about management overall, as in osteoporosis, even in non-diabetes, look at calcium, look at vitamin D, adequate calcium and vitamin D, and also active lifestyle, enough exercise, not only aerobic exercise, but also muscle building or strength building exercises are important. Limiting alcohol and fall reduction strategies are also important in reducing fracture. What about the use of anti-osteoporotic drugs in diabetes? Do they fare any differently from non-diabetes? Well, this is a good meta-analysis which is looked at almost 95,000 individuals, of which only a small fraction had diabetes. About 7% had type 2 diabetes, from various trials covering bisphosphonates, selective estrogen receptor modulator like raloxifene, menopausal hormone therapy, denosumab, and odronacatib. Of course, odronacatib is not available in our country. So overall, it was found that there is no difference in the response rate between diabetes and non-diabetes. Similarly, if you looked at the bisphosphonate studies separately, again, there was no significant difference. However, if you look at the denosumab study, denosumab incidentally is one of the newer anti-osteoporotic agent that is available to us and which is very effective in improving bone density, reducing fractures. But in type 2 diabetes, it's been found, at least in the first 3 years of this usage, there tended to be higher non-vertebral fracture risk in type 2 diabetes, whereas it did perfectly well in non-diabetic. However, when we looked at the 10-year extension phase of this whole of this study, once again, there was no difference between diabetes and non-diabetes. So overall, if we are looking at which anti-diabetic, anti-osteoporotic treatment to use in diabetes, probably it's better to fall back on our age-old bisphosphonates, whether oral or intravenous, as either of them have been shown to be quite effective. And then we all know that sarcopenia is a major issue in our country, not only visceral obesity, but sarcopenia is important, assessment of sarcopenia and its management, which has to go with adequate protein, also adequate exercise programs, which will include resistance exercise training as well, not just the simple aerobic exercise, which should help us sort of have a better bone health for our people with type 2 diabetes. So type 2 diabetes and osteoporosis, I'd like to conclude by suggesting that would be managed as elsewhere with lifestyle intervention first, limiting alcohol intake, with smoking cessation and adequate exercise, not only aerobic but also resistance exercise, adequate calcium and vitamin D. In terms of treatment of hyperglycemia, possibly avoiding thiazolidinediones, especially in postmenopausal women, is important. And in terms of, we also need to treat the other comorbidities. And in terms of drug treatment for osteoporosis, probably bisphosphonates are to be considered over others, especially denosumab. So with these, I would like to conclude and thank the organizers once again. And if you have any questions, I'll try and answer. Thank you very much.
Sir, I have a question. Sir, is the management of osteoporosis different in patients with type 1 and type 2 diabetes? That is one. And what is the role of teriparatide, sir, in management of these patients?
Right. So first of all, for type 1 diabetes, osteoporosis is more often, more common. One of the best things, the first things to do there, their insulin actually is helpful, protective, is an anabolic hormone. And getting the glucoses under control would be the first step. And thereafter, the management principles are generally similar to non-diabetic or even to type 2 diabetes. The other question was, exactly, I did not hark upon teriparatide, partly because the meta-analysis that we looked at had very small number of individuals on teriparatide. However, if you look at the bone health in diabetes overall, one of the major pathogenetic mechanisms is low bone turnover. And teriparatide is a bone forming agent. The others are anti-resorptive agent. So theoretically, teriparatide should have a better, bigger role in type 1 diabetes, but we do not have enough number of, a large number of studies or large number of people in the studies to actually make this recommendation yet.
What about these patients?
Yeah,
because you'll be using bisphosphonates for a long time.
Yeah.
So what is the present situation for these drug holiday?
Right, so what our chairperson, madam, was suggesting is drug holiday in osteoporosis management. The concern comes from the fact that long-term use of bisphosphonates, not only bisphosphonates, even for denosumab, has been shown to be associated with increased bone density, but once again making the bones more brittle and a risk of atypical femoral fractures. The other concern, of course, is also related to osteonecrosis of the jaw. In practice, so general current recommendations are that you can continue oral bisphosphonates once you start for 5 years, even up to 7 years. If you're using intravenous zoledronic acid once a year, possibly you use it for 3 years, maximum up to 5 years. Thereafter, there is a suggestion that you provide a drug holiday, and then you follow up, you look at bone turnover markers, and then when the turnover markers once again start to go high, then you reinstitute treatment. And that again, there is no different recommendations made in diabetes compared to non-diabetes.
There is a slight increase in the bone density. So, is there any study where we can use the combination of denosumab and anti-resorptive agents together in these patients, sir?
Absolutely. There are studies currently available which show that combined use, in the past it was a no. You do not combine the two, it does not give any advantage. Now we have evidence that if you combine the two, the bone density at the end of 1 year has been shown to be better. What we do not have data on is whether this actually translates into lower fracture risk, which we have to await on. And denosumab, I'm sure others, physician colleagues in the audience would also know, despite it being such an effective agent, once you stop, your bone density tends to go down very quickly, and your fracture risk tends to go up very quickly. So once you've started someone, possibly we need to counsel that this is not for short term, this is long term. And up to 10 years data, at least for denosumab, is available to suggest that it does not increase significantly the risk of atypical femoral fracture. So up to 10 years possibly you can use. But once again, in the lifetime of an individual, if you start someone at 65 years, today people are living to 85 years. So what happens after 10 years, I think it's still up to a discussion with the patient and the clinical condition. There are no guidelines to guide us there.
Thank you, sir. And I request any questions, more questions from the audience.
A very nice exposition, sir. Just wanted to know what is the mechanism of decreased bone mineral density with pioglitazone? And is there any intervention that we can do to counteract that mechanism so that we can continue with pioglitazone without worrying too much about the osteoporosis?
Yeah, again, that's, there are a number of mechanisms suggested. Possibly the easiest to answer is that pioglitazone acts on the mesenchymal progenitor cells, which give rise to both adipocytes and also to osteoblasts. So there is differentiation along the adipocyte pathway, so there is sort of shunting away from osteoblasts, so there is less bone formation. That's possibly the most commonly touted reason for pioglitazone-induced bone impairment. As to how best we could mitigate the condition, of course, adequate calcium, vitamin D, exercise possibly could help, but we do not have evidence that that works. And clearly, I would have been very happy if I could have continued pioglitazone far more number of patients, especially women. I tend to stop them beyond their menopause, despite having good control. And thereafter, you have to struggle with other agents in order to get the glucoses under control. But that's, sometimes we need to continue with discussion, with documentation that we have discussed, and then we continue.
One more mechanism is supposed to cause the RANK ligand activity is modified by the pioglitazone. That is also supposed to cause the increased osteoporotic activity. rank ligand activity is modified by the pioglitazone. It is other theory supposed to cause the osteoporotic, increase the osteoclastic activity, cause the osteoporosis.
Thank you so much. Thank you.
So we end the session here and over to the organizers.
Thank you, Dr. Shubhankar, and thank you all chairperson and panelists. Please proceed on the right side of the dais for your. So now shifting gears from diabetes to thyroid, rather a combination of diabetes and thyroid disorders. And to speak about this topic, we have our eminent speaker, Dr. Robin Maski, who has come all along from Dhahran, Nepal, to just give his lecture. So it would be going to be a very wonderful lecture, though it's the last session and everybody's eyes are on the back, but still I think Dr. Robin will keep you winding. So for this session, I would invite Dr. Shivam Verma and Dr. P.K. Pandey sir as the chairpersons, and Dr. M.C. Srivastava sir and A.C. Rastogi sir for panelists. Dr. Robin. I would also request Dr. P.K. Pandey sir to please introduce Dr. Robin Maski.
Hello. I'm pleased to introduce Dr. Robin Maski from Nepal. He's Professor, Department of Internal Medicine, BPKIS, Dharan, Nepal. He has published 112 research papers. He has written 10 chapters in among various books. His area of research interest is diabetes, thyroid, pituitary, adrenal, and reproductive endocrine. His current designation is HOD, Professor and HOD, Internal Medicine, BPKIHS, Nepal. His current affiliation is Executive Board Member, Internal Society of Endocrinology. He is Editor-in-Chief, Journal of Dean. He is currently President, Diabetes Nepal, Dharan Chapter. He is past President, 2024 Dean. We welcome him for a lucid interaction.
Thank you, Chairpersons, for nice introductions. And at the outset, I would like to congratulate LDSCON team, and especially thank KP Chandra, Dr. KP Chandra, Dr. Nitin, and Dr. Mukesh, and all organizing committee for inviting me to this conference. So the topic given to me today is diabetes mellitus and thyroid disorder, a dual endocrine dilemma. So I am from eastern part of Nepal, you can see there, from Dharan, the BP Koyala Institute of Health Science, and it was Nepal-India Partnership Project since last 30 years. So it's in eastern part of Nepal. So these are my outlines of my talk today. So since the topic was given to me, so are you aware like the term diabetes and thyroid was coined even before the use of insulin? So you may be surprised. So it was published in 1920, the thyroid diabetes term was published. So it was even before the discovery of insulin. Now the term called dual endocrine dilemma is coming. So why this is the term dual endocrine dilemma? Both these glands are endocrine glands. So I will be discussing why is a dual endocrine dilemma in the subsequent slides. So before going to that, let's see the prevalence of thyroid dysfunction in patients with diabetes mellitus. So this is the prevalence in type 1 diabetes. You can see around 70 to 30% with autoimmune thyroid disorder and type 1 diabetes. Risk factor for autoimmune thyroid disorder is all are aware, like female sex, when the patient have TPO antibody positive and more duration of diabetes, and the risk of hypothyroidism in children with type 1 diabetes is more as compared to adults, is around 25%. And the risk factor of hypothyroidism in children is usually because of poorly controlled diabetes. Regarding the prevalence of diabetes in type 2 diabetes, it is quite lesser than of type 1, is 6 to 20%, and risk factor is same as that of type 1. And risk factor of hypothyroidism type 2 diabetes more than 65 years age it is more common in female, and it's more common in non-obese, but it is more in TPO antibody positive patient if the patient have hypothyroidism type 2 diabetes. And risk of subclinical hypothyroidism type 2 diabetes is 10.2%. So these all are the Western data. And when I Google like the study of thyroid and diabetes in India, you can see it is the prevalence around 18 to 29%, and most are subclinical hypothyroidism. And when I see Google in Nepal, it was around 36%. So and it is similar to the Nepal and India, the prevalence is similar, and the most common is subclinical hypothyroidism still. So I am proudly like to share you my reference given in Williams text of endocrinology, in the Southeast Asia edition, thyroid disorder, a South Asian perspective. It was written by our Professor Ambika Gopala Unikrishan sir, and he has quoted the articles which I have published. The prevalence of hypothyroidism in type 2 diabetes is only 4% in Nepal. So this was the study which I have done in Nepal, and we found that the prevalence of hypothyroidism diabetes was 4%. So now the term comes, why there is a dual endocrine dilemma between the diabetes and thyroid gland. And what? Because it is not the dual endocrine dilemma, these are the similar organs. They have both etiological similarity, and they are similarity in various forms. Like these are both endocrine organs secrete the hormones. They have the contributing factors for both the endocrine glands are autoimmunity, and the genetic factors are responsible for the pathophysiological link. So they are both linked pathophysiologically. So if you see this cartoon, it is quite complicated, but I will make it simple. So whenever we have a appetite, so it all depends on the appetite which we have listening since morning. So the appetite is controlled by the paraventricular nucleus and ventricular nucleus in the hypothalamus, and this depends on the food intake. And glucose and lipid metabolism is targeted in all the organs like liver, white and brown adipose tissues, pancreatic beta cell, and skeletal muscles. So how does this thyroid gland helps in causing the pathophysiological link between this diabetes and thyroid? So you can see in this cartoon that the thyroid gland have effect on the increase in glucose output, increase in gluconeogenesis, all these factors. And white adipose and brown adipose tissues, also the thyroid hormone receptors are acting on that, and the active hormone like T3 helps in increase lipolysis, increase thermogenesis, increase expenditures, and likewise the beta cell, the thyroid hormone receptor will act on the beta cells, and it causes with the help of MAFA, and it causes the beta cell maturation and increase insulin secretion, thereby causes increased glucose absorption, increased production. And in the muscles, it also acts by secreting the adipokines and myokines, the T3. So basically there is the control of hypothalamus pituitary thyroid axis from the hypothalamus, and thyroid hormones, the neonatal endocrine, the neonates have the beta cell also, and they are equivalent to the thyroid hormone receptors. So all are causing the synergetic action with the diabetes and pancreatic glands and the thyroid glands. So these are the effect of thyroid hormone of glucose metabolism. It acts on the intestine, liver, pancreas, and all leads to the hyperinsulinemia and glucose intolerance, thereby causing the peripheral insulin resistance. So I told there are some genetic factors with the association between the diabetes and thyroid. So if you see the confirmed joint susceptibility gene, there are various genes, mostly the class 2, HLA class 2 genes, and CTL4. CTL4 genes are associated with type 1 diabetes, and that's why these CTL4 genes are associated with type 1 diabetes and thyroid disorders. Likewise, the candidate susceptible genes are there are lots of list you can see here, but in Asians, if you want to see, the PTNP22 is responsible for the link between thyroid and diabetes. So what is the link of autoimmunity between thyroid and diabetes? So as you have heard in the today ADA updates of 2025 also, one of the speakers was telling there is a link of autoimmune thyroid disorder with type 1 diabetes. Yes, correct. So type 1 diabetes and autoimmune thyroid disease coexist together. Type 2 diabetes and thyroid disease also coexist together, and both diabetes and thyroid disorder have common comorbidity. So obesity can be seen in diabetes also and hypothyroid also. Weight loss is seen in hypothyroidism also, and if the patient have uncontrolled blood sugar, they come with the weight loss. Dyslipidemia, depression can be seen in hypothyroidism also, and diabetes also as a comorbidities. So they are interlinked with each other. How does it impact on therapy? I will be going more on the subsequent slide. If you see the diabetes mellitus and thyroid disease, how does it causing the dual endocrine dilemma, or it causing the interlink between each other, you can see with this slide. So if the patient is diabetes in euthyroid individual, there is a, you can see in this figure, there is a decreased TS response to TRS, and there is impaired nocturnal TSS peak, and they usually present the decreased serum T3 and like the pictures of sick euthyroid or low T3/4 syndrome. And if the patient is in diabetes and hypothyroidism individuals, the effect of glycemia is poor glycemic control, and they are more risk for this thyroid optic neuropathy. If you see the hypothyroidism in euglycemic individuals, they have glucose intolerance in 50% of cases. Hypothyroidism in diabetes also have deterioration of diabetes control. Hypothyroidism diabetes have periods with recurrent hypoglycemia. And in autoimmunity in type 1 diabetes, we have already seen there increased prevalence of the disease. So how is thyroid dysfunction related to type 1 diabetes? So it is more common associated with the Hashimoto thyroiditis, grave disease, postpartum thyroiditis, and you must be aware of APS type 1, type 2 syndrome. In APS type 1, the hypogonadism is there. In APS type 2, the type 1 diabetes is associated with the hypothyroidism, but is usually associated with APS type 3. And you can also have co-occurrence between celiac disease and Addison disease. So the key factor responsible for interplay between type 1 and diabetes and hypothyroidism is they are interlinked with the genetic factors in some area. They are common biochemical factors, they are related into hormonally, they have autoimmunity and clinical overlap. As I already told, they can have weight gain in both hypothyroidism and diabetes and therapeutic implications. So how does hypothyroidism causes hyperglycemia? So whenever there is a hyperthyroidism, there is increased metabolism, so it causes increased glucose catabolic pathway causing increased lactate formation, lipid catabolic pathway causing NAFA, hormone sensitive lipids are stimulated causing NEFA, and there is a increased glucose output in liver and causing hyperglycemia. So whenever there is a high prevalence of hypothyroidism type 2 diabetes, there are similar symptoms as already told. If there is a poor glycemic control, patient present with the weight loss, and also in the hyperthyroidism they can present with the weight loss. If the patient hyperthyroidism with the diabetes, they can land up with the decay, diabetic ketoacidosis. They are more risk for cardiovascular risks, and they also mark the thyroid symptoms in the severe hyperglycemia patients, and poor glycemic content uncontrolled hyperthyroidism leading to diabetic ketoacidosis. And hypothyroidism type 2 diabetes are more prone for metabolic syndrome, increased cardiovascular risk because of increased insulin resistance. So what is the key responsible factor, or what is the key link between hypothyroidism diabetes in nutshell? So it causes the decreased beta cell mass, increased insulin resistance, there is a clinical overlap, and regarding the therapeutic implication, we will dealing with the subsequent slide. So in the summary of both hypothyroidism and hypothyroidism diabetes, both have a clinical overlap. Obesity, dyslipidemia, and depression is seen with both hypothyroidism and diabetes. Autoimmunity is seen with type 1 diabetes and thyroid disorder. We can also see the poor glycemic control and hypoglycemia can be seen on undiagnosed thyroid disorder. And how does the anti-diabetic effects on the TSH level is also one of the important factors. It causes a decreased TSH. So whenever the patient is taking metformin and they have a hypothyroidism, you can give metformin that can cause a TSH level, then it may decrease the requirement of levothyroxines. They can be the altered absorption of thyroxine due to other drugs, for example, calcium. If you are giving the patient is having diabetic kidney disease and taking calcium and iron, and if you give a thyroxine, they can have interactions, and they don't have a control in the thyroid levels. So relation between hypothyroid and insulin, which I have already told in the previous slide. So what are the effects of various drugs in coexisting diabetes and thyroid disorders? So metformin is seen in this figure, like it reduces the TSH level, it reduces the risk of thyroid cancers by decreasing the thyroid volume and nodule size. It may be a promising therapy patient with the thyroid disorder. Sulfonylurea, but in opposite hand, it increases the risk of thyroid cancer and risks of hypothyroidism and goiter. Thiazolidones have a PPR, acts on PPR gamma agonist, which have a thyroid hormone receptor, also have their same cells, so it inhibits the activity of thyroid hormone receptors and increases the TSS. And we have also heard about the insulin-induced hypoglycemia, drug-induced hypoglycemia in a previous slide today morning, like non-diabetic causes of hypoglycemia. So carbimazole have to found to be causing insulin autoimmune syndrome that is known as Hirata syndrome. Okay, and it can cause hypoglycemia in patients with diabetes, both methimazole and carbimazole. Levothyroxine reduces the fasting and postprandial blood sugar level, reduces the glycosylated hemoglobin also. Incretin mimetings, which is the today's lots of the talks was focused on GLP-1 agonist and SGLT2. So GLP-1 agonists, we are all aware, it can also cause the medullary thyroid carcinoma. So we have to be cautious while dealing with the diabetes and thyroid disorder, and palpate the thyroid gland, see whether the patient have a thyroid nodule or not, and send the patient for the ultrasound of the neck and work up for the whether they are risk for medullary thyroid carcinoma or not. So what is the recommendation for major diabetes and endocrine practice guideline on thyroid screening in patients with type 2 diabetes? So since 2000, there has been guidelines has been changing as for ATA, AAC, British Thyroid Society Association. So since then the various recommendations has come. So recently in 2019, what they have recommended by British Thyroid Association is telling that you can do the TSS and TPO antibody as a diagnosis in type 1 diabetes in every year. In type 2 diabetes, routine annual thyroid testing is not recommended. Only you can do the thyroid testing if you are suspecting the patient with the thyroid disorders. As per ADA, they have told in type 1 diabetes, TSS, TPO antibody and thyroglobulin antibodies evaluation and diagnosis is done, and thereby 6 monthly, and depending upon the risk factor, we have to do this screening of the thyroid TSS in the diabetes patient. In type 2 diabetes, thyroid palpation should be done as already told in all the diabetic patients, and TSS in adult more than 50 years of age or patient with dyslipidemia, increased lipids and all the triglyceride and total cholesterol, increased LDL, we have to do the TSS. According to AEC, American Association of Clinical Endocrinologists, they have told you have to do thyroid palpation both type 1 and type 2 diabetes. In type 1, we have to do the thyroid palpation at regular interval and in patient with goiter and autoimmune thyroid disorders. In type 2, we have to do the thyroid palpation TSS at diagnosis and regular interval in patient with goiter and autoimmune thyroiditis. These are all the Western data. Whatever the Indian screening, I will be coming substitution slide. Before that, what is the benefits and limits of screening program in patient with type 2 diabetes? If you don't do the screening in asymptomatic thyroid disease is frequently absorbed in patient with type 2 diabetes, so we will be missing that. Patient won't be having controlled blood sugar, the patient won't be having their lipids may be controlled with the, if they have a thyroid disorder and diabetes, so we have to control the thyroid, and that's, depending on that, the sugar level and lipids will be controlled. Undetected thyroid disorder are compromise the metabolic control and amplify the cardiovascular risk events. They can also land up the patient with the stroke and myocardial infarction. So it's very important to screen them. The screening of thyroid disorder could prevent the high cardiovascular complications, which I have already told. And diagnosis of thyroid disorder in a patient with type 2 diabetes is difficult because some oral anti-diabetic drugs like metformin, sulfonylurea, GLP-1 can interpret with the evaluation serum TSS level. So we have to do the meticulous thinking, critical analysis before doing the diagnosis of thyroid disorder in type 2 diabetes. Sometimes the subclinical thyroid disorder can progress to the low rate, suggesting a long-term screening program. That's why you should not do screening all the patients with diabetes and thyroid disorders. The use of age-specific TSS range should be considered to avoid the misdiagnosis of hypothyroidism in elderly patients with type 2 diabetes. And all the country has their own TSS, age-specific TSS range, and I think the India has already developed that. In Nepal, we have not developed till now. And India has developed that for both the euthyroid individuals and thyroid disorder in pregnancy also. There are insufficient data to assess the specific test for the screening. So the exact interval of periodic screening and the cost-benefit ratio should be considered while doing the screening of patient for thyroid disorder in diabetes. So what is this all were complicated. What is the simplified algorithm then for thyroid screening in diabetes? So if the patient is euthyroid, if the patient is type 1 diabetes and type 2 diabetes, you can do TSS and TP antibody and thyroglobulin antibody in the type 1 diabetes patient who are suspected to have a autoimmune thyroid disorder or Graves' disease. In type 2 diabetes, you do the TSS if the patient have dyslipidemia and women are more than 50 years. See the same thing, slightly modified. So when we are all aware of that, if the patient have a subclinical hypothyroidism and thyroid disorder more than TSH level more than 10, you have to treat. If the patient have a subclinical hypothyroidism with dyslipidemia, they are planning for pregnancy, infertilities, they have goiter, then we have to treat. So it's the same thing for the thyroid dysfunction and euthyroid. So regarding the Indian guidelines which I have told as per RSSDI, the grade B recommendation, there is insufficient evidence to support annual TSH screening patient with type 2 diabetes. They have told to screen the patient for high risk, like for example, elderly women, the patient is having uncontrolled diabetes, patient with frequent hospital visits, and patient with pre-diagnosed autoimmune thyroid disorder, Graves' orbitopathy. Grade B recommendation, annual TSH screening along with TPO antibody is recommended in type 1 diabetes in all patients regardless of the age, clinical presentation and gender. In patients with subclinical hypothyroidism, more frequent TSH screening can be performed keeping in mind the economic consideration of the patient. That is very important in our part of the world, both Nepal and India. Another grade B recommendation is in patients with type 1 diabetes, anti-TPO testing at the time of diagnosis should be done along with annual TSH screening is recommended. For patients with type 2 diabetes, TSH is done at the time of diagnosis and it is done every 5 years, not annually, like that of type 1, as the age more than 35 years of age. And annual screening can be recommended in high-risk cases like if the patient of diabetes have a complication like neuropathy, nephropathy, retinopathy, subclinical hypothyroidism, positive anti-TPO antibody and dyslipidemia. They have also told by Indian guidelines, RSDI guidelines of India, thyroid gland palpation should be recommended in all the patients with diabetes with positive family history of thyroid cancer regardless of the glycemic presentation. Because if you are giving GLP-1 agonist, if you missed medullary thyroid carcinoma, you will be aggravating his cancer and you will landing up with the problem. So what is the summary of Indian evidence? So in grade B recommendation, what they have told is annual TSH screening should be done in all patients with Indian patient or Indian subcontinent like Nepal with type 1 diabetes, especially pregnant women in whom normal TSH cutoff must be considered. We all are aware of that. In first time, we have to keep between 0.1 to 2.5, and second 0.2 to 0.3 like that, 3, and third time 0.3 to 3. So for patient with type 2 diabetes, annual TSH screening is recommended in euthyroid patient who have a TSH level more than 2.5 microunit per liter. And patient with thyroid disorder and diabetes must be regularly screened for nephropathy and neuropathy also. Because in the nephropathy patient, they can also have a pallor, edema, leg swelling. You may be missing that patient as a hypothyroidism. So they have similar features, no? So we have to be cautious. And they can have neuropathy. Both the thyroid disorder and the diabetes patient can also have neuropathy. So we have to screening all the patients having these symptoms for diabetes, for TSS, and TSS, the hypothyroid patient having these symptoms. We have to ask the history of diabetes and go ahead with that. So high-risk patient including patient with hypertension, neuropathy, nephropathy, uncontrolled blood sugar and dyslipidemia have to be screened annually with the thyroid function test. Individual case presentation of the patient must be considered to decide the frequency of TSH screening since the burden of hypothyroidism is much more higher in the Nepal and India. So I was focusing more on the Indian guidelines because we have to be proud of ourselves with our guidelines than following all the Western and European guidelines. So grade A recommendation is for regarding the treatment of anti-thyroid drugs in patients with diabetes. So it's taken from same RSDA guidelines. So we all are aware, like we start with the levothyroxine and the dose is 1.6 microgram per kg body weight. We have to start with that. And metformin can be safely prescribed in patients with diabetes and thyroid disorder. But we have to regularly monitor the thyroid function test in patients who are thyroxine and metformin because metformin has been found to decrease the TSH level. And other OHs like sulfonylurea, GLP-1, pioglitazone must be selected in caution because pioglitazone has been found to be aggravating the Graves of the orbitopathy, because this PPR gamma receptor is also found in the orbits and it can also aggravate that. So you have to be cautious while giving that drugs in the patient with the Graves orbitopathy. In the patient on metformin levothyroxine regimen, the dose of levothyroxine may be reduced because metformin itself can decrease the TSS. All insulin dose is recommended for elderly patient along with the necessary dose reduction should be there. And clinical indication and patient preference can indicate treatment choice of antithyroid drugs versus radioiodine ablations. Some little things about how to deal with thyroid disorder in pregnant women with diabetes. So we have heard about that, like there are various mechanisms like immunological mechanism, genetic factors, epigenetic factors, environmental, all are causing this thyroid disorder in pregnant women. And if you don't treat, they can have a both maternal and fetal adverse outcomes. So we have to treat the patient with thyroid disorder in pregnant women also. And what a guideline I recommend, which I have already discussed. In 2017 guideline of ATA, they have told to check TSS in pregnant women with type 1 diabetes and other autoimmune disorders. They have also they do not recommend universal screening for all the patients who are pregnant or planning for pregnancies. Okay, all the patients should not be screening. Screening should be done in following risk factors which are listed here. Mostly the age more than 30 years, and they have a family history, they have risks for the other autoimmune disorders likewise. So BTA and British Thyroid Society, Endocrine Society also are considering same, but Korean and ACOG are not recommending so universal screening of the thyroid function test in the pregnant woman. So at the end, I want to end by telling by some essential points or take-home messages of today's diabetes and thyroid talks are: autoimmune thyroid dysfunction is more common, around 70 to 30% with patients with type 1 diabetes. Thyroid dysfunction is more common in patients with type 2 diabetes also than other general population. If there is a patient have a pre-existing diabetes mellitus, we have to screen for if they have a uncontrolled blood sugar, if they have uncontrolled lipids level, we have to screen for the thyroid dysfunction. They may be having hypothyroidism, that might be precipitating the decay. They might be having the hypothyroidism, that might be precipitating the dyslipidemia. And so insulin treatment should be adjusted in patients with diabetes after occurrence of thyroid dysfunctions. And hyperglycemia should be rehabilitated in hyperthyroid subject after the control of thyroid dysfunctions. Because if you control before, then it may aggravate the decay. That's why we have to control first the thyroid hyperthyroidism or Graves' disease, thyroid storm, then go ahead with the control of the blood sugar. And as I've already told, GLP-1 receptor agonist or liraglutide is not recommended in patients with personal family history, medullary thyroid carcinoma or type 2 multiple endocrine neoplasia. And pioglitazone should be administered to diabetic patients with should not be administered with clinically active Graves ophthalmopathy. And at last, I want to thank all the LDSSCON committee for inviting me and conducting such a beautiful, excellent academic feast. Thank you. Thanks a lot. If you have any comment or questions, I am ready to answer that.
That can be over the glass of wine, I think. I think every good thing comes to an end, and so let this be too. And we really have left some real wonderful lectures in the morning sessions, and we'll be leaving some good fond memories. Thank you, Dr. Robin.
Thank you.
And I request all the chairpersons and speakers to please proceed to the felicitation. And finally, as a customary note, I would request Dr. Muklesh sir to please present a vote of thanks.
So now, as it's a customary, so I will sincerely like to thank each one of you, first of all, because I still see all of you sitting. Nice lectures over here. We have tried to give you good clinical topics coming through experts, those who are well known in those fields. And if suppose you are there sitting at this time, that proves that our effort as a overall effort is now proving to be good. Certainly, we'll try to continue with this sort of thing in future, as we have been trying in the past as well. The motive remains to dissipate knowledge to the best. And in this endeavor, each and every one of you has contributed significantly to the success of this conference. I will also like to thank our counterparts, the Nari Shakti, which is still busy. Backstage, they are not seeing in the front, but yes, without them, this program would have been so smoothly running, immediately getting the pictures within a few minutes to deliver those certificates printed with those actual live pictures of the respected faculty and the speakers is a marathon task which is being continually done, none other by our counterparts, those who are there in the backstage. I'd also like to thank the pharma people all around. They have been supporting us for continuing this. So once again, thank you so much, all pharma people here, those who are there in the hall or those who are there outside. I'd like to pass on my sincere thanks for the same. At the same time, I will also like to thank my own staff from my hospital, those who have been there with me throughout the day and doing whatsoever little things they have to be done for this particular conference. And then the event manager of this program, and that is Umair with the bag there in the center, and the audio video that was absolutely flawless throughout the time, the screen and whatsoever decor, whatsoever you are having has been done by Mr. Umair, who is the event manager for this particular event. So big thanks for you also. You have been supportive throughout our past endeavors as well. So to my all seniors, to my all colleagues, to our fellow men, to the organizers, to my staff, to the staff of KP Chandra, and then I will like to specially mention about KP because people have been asking me ये live अचानक से scientific brief कैसे चले आ रहा है, ये कौन कर रहा है? मैंने कहा वो बंदा बैठा है ना एक बगल में, वो खुद AI है. So he is so hyper dynamic, full of energy कि वो जब भी एंटर करता है ना कहीं पर भी तो कहीं ना कहीं एक एनर्जी लेवल चेंज होता है उस पूरे इलाके का. So this is what KP is, and the scientific briefs whatsoever you are getting on your mobile has been compiled by him. So each and every person, Dinesh, silent worker in the background, all faculties have been contacted by him through these last 15, 16 days, and he has been doing it day in and day and night, continuously, and the end result is there. Most of our faculties, they were here, barring for maybe few, everyone attended and contributed in their positive manner for this conference. So with this, and I will not miss on anyone, Vivek or Nitin, or maybe people, those who are not here, Arun and Santosh sitting in Australia, I like to also mention because he has been giving his inputs. Though he is overseas, he is not here in India. So we as a group are certainly here, bonded together with our counterparts. They are there now free, so probably they can also come forwards. And this is where I'll end my words today. And now another 45 minutes of wait before these hotel people, they will settle down with the dining part, and the music people, they will settle down the stage, and then we will have live music with your contributions there itself. There also we'll be requesting Dr. Dalela बहुत बढ़िया गाते हैं, उनको भी कहीं ना कहीं invitation दूंगा, रोक के रखा है मैंने अभी. So now let us have good time of enjoyment after that education feast. Now here the cocktails and dinner, they will be open probably after 30-35 minutes from now. So we have some waiting time, relaxing time to chit chat and network. And then later on, we'll continue with the music and rest of the things from there at around 8 or 8:15. Thank you so much, and sorry if I have missed someone in the process. So once again, Dr. Rajiv Avasthi, Shaili Avasthi, everyone, and is just a bond that takes us together through the process. Thank you so much for being here. So wait for another 30-35 minutes, and then we'll continue with the music and the cocktails and the dinner. Thank you so much.
मैं कुछ बोलूँगा नहीं, मुझे फ़ोटो खिंचवानी है, सुबह से एक भी फ़ोटो नहीं खींची मेरी। अरे फोटोग्राफर भाई मेरी फ़ोटो लो भाई, मेरा ही फ़ोटो मिसिंग है। हाँ, डॉक्टर मुकलेश ने सबका नाम लिया पर शायद खुद का नाम लेना भूल गए। आई थिंक ही इज़ द सोर्स ऑफ इंस्पिरेशन एंड हम लोग सब उनके पीछे हैं। जब उनका 11 बजे मैसेज आता है, सुबह 5 बजे फिर आता है, लगता है यार वाई कांट वी ऑल्सो कंट्रीब्यूट। तो बंदा 4-4 घंटे सो के सारा अरेंजमेंट कर रहा है। एंड आई थिंक ही इज़ द सोर्स ऑफ इंस्पिरेशन who made us work hard for the last, let us say, 2-3 weeks and maybe 6 months down back ago. So 3-4 हफ्ते हम लोग शायद 4-5 घंटे सोए हैं, लेकिन the inspiration has come from Dr. Muklesh and Dr. Muklesh. आइए आपका भी फोटो हो जाए। 2 ही लोगों के फोटो मिसिंग है।
थैंक यू माय LDSS टीम। बाकी सबको तो सर ने थैंक्स कह दिया है, बट मुझे लगता है कि LDSS टीम ने मुझे इनकॉर्पोरेट किया है। आई एम सो लकी। राजीव सर, मुकलेश सर, द डायनेमिक पर्सनालिटी, माय KP ब्रदर, दिनेश बॉस, अरुण, everybody, Tanushri ma'am, Shaili ma'am, better halves, everybody has been so dynamic and helping that we just feel elated when we are in this group. So thank you very much. Thank you, Muklesh sir.